Hello, everyone. Good evening and greetings from Canada. We have a couple of cases to present and a article as well. So I'm Jen Grossman. I'm an adult hematologist and also see patients with primary immune defects. I'll also introduce my colleague, Candace Rypien, who is doing a fellowship in PID right now, having completed an infectious disease fellowship as well, and Nicola Wright, who is a pediatric hematologist and immunologist. So thank you all for coming tonight, and we'll hope to keep this educational and entertaining for you. So I'll be presenting first a case of early onset CVID and solid organ transplant. So patient KA is a guy who was referred to me from North Battleford, Saskatchewan. And if you don't know where that is, it's just really far north in Saskatchewan, which is kind of in the middle of the country. He was referred to me by a colleague in 2015. He had an extensive infection history dating back to infancy with pneumonias occurring up to age 5. He actually required hospitalization for those, even had bronchoscopies. He had ear infections requiring tubes at age 6, and at the young age of 5 was actually found to be hypogammaglobulinemia and was started on immunoglobulin replacement at that point. That really reduced the number of infections he was having. He had no history of herpetic infections, fungal, or NTM infections up until then. As an adult, really the only things he could tell me about were the occasional like cold, nothing major, resolved quickly, maybe needing 1 to 2 courses of antibiotics a year. He had a GI infection after a trip to Mexico. And then actually when I first saw him, he had a cough and I had him do a sputum sample and he grew H. flu. He had a CT scan done in 2014 in Saskatchewan. The copy was sent to me showing post-infective fibrosis with scarring in the right lower lobe with bronchiectasis. There was mild fibrosis and bronchiectasis in the medial segment of the left lower lobe and left perihilar region, and progression of reticular nodular infiltrates in the right upper lobe. In terms of his liver, in about 2007, he noticed increasing fatigue and had an episode of jaundice. Ultimately was diagnosed with primary sclerosing cholangitis based on MRCP and biopsy. He had ongoing issues with fatigue and pruritus, and it was actually quite debilitating for him. He had to quit working and just looked unwell all the time. There was evidence of portal hypertension, and he had a MELD score of 16. In February 2015, he went to Malaysia to have a mesenchymal stem cell transplant from a donor bank to try to treat his liver. And he was put on the transplant list for a liver transplant, but he was deemed non-urgent, so was really nowhere near the top of the list. From a hematologic point of view, in 2014, they noted a left cervical node, which was biopsied and initially reported as marginal zone lymphoma in Saskatoon. But this was reviewed and redefined as an atypical lymphoid hyperplasia. He had splenomegaly and thrombocytopenia, as well as lymphopenia. I was never sure whether the splenomegaly was secondary to his liver disease, whether the thrombocytopenia was secondary to the splenomegaly and the hepatomegaly, and similarly the lymphopenia. So this was the initial testing that I did on him. So the blue means it was low and the red means it was high. So he had mild anemia at 129, platelets were 68, lymphocytes were 0.3, and he had a slightly low albumin, not surprisingly. And then, of course, his liver enzymes were all significantly elevated. In terms of his immunologic testing, I did what we call our immune deficiency panel, looking at the T and B cell subsets. You can see his total CD3 count was low, as well as his CD4, so 0.17. He wasn't on any PJP prophylaxis at that point in time, and to that time had not developed any problems with opportunistic infection. CD8s were good, but CD19 was also decreased, and his NK cells were also low. When he first saw me, I checked his IgG, and he was actually on immunoglobulin replacement with an IgG of 1.95. So that was a little low, so we adjusted his dose and really had undetectable immunoglobulins otherwise. I did a mitogen stimulation assay. Because he was lymphopenic, they didn't have a great sample, but the director of our flow lab actually emailed me and said he'd had a good response to PHA and the cells appeared to go under blast transformation, but they didn't proliferate after that, which I thought was interesting. It was something that she had never seen before. So went on to do genetics and got results in July 2016, courtesy of the NIH groups. I'm not sure what. I'm sorry about the echo there. I'm not quite sure what's happening. Okay. So he was found to be heterozygous for a mutation in NF-kappa B2. It was a new mutation that hadn't been previously identified. They also went on to test his father, who had the same mutation, but was actually asymptomatic until the age of 48 when he was diagnosed with rheumatoid arthritis. This case was actually published as part of a kind of case series by the NIH group in Blood in 2017. It was found that this was actually a gain of function mutation. So in 2014, Chen et al. Had reported heterozygous dominant negative NF-kappa B2 mutations in CVID patients, causing defective processing of P100 to P52 and subsequently reduced translocation of P52 to the nucleus. Clinical consequences in that report was found to include antibody deficiency, lymphocyte dysfunction, central adrenal deficiency, alopecia, and trachonikia. KA's mutation is a heterozygous nonsense mutation, but leading to a gain of function and a combined immune defect. So this protein, E418X, showed reduced inhibitory function and therefore increased gene expression and cytokine generation on activation of both canonical and non-canonical pathways. He and another patient described in that paper had hypogam with antibody deficiency, recurrent respiratory infections, and lymphoproliferation, kind of typical things for CVID. But also some of the other patients had EBV, CMV, warts, candidiasis, PJP, non-caseating granulomas, T-cell LGL, and PSC. Though I have read PSC can be associated with CVID. This was kind of more in keeping with a combined immune deficiency phenotype. So there was a more recent paper in 2019 published by Clement et al. Looking at 15 novel cases of NF-kappa B2 mutations, and also this paper reviewed 35 previously reported cases. So the mean age of onset of symptoms in these patients was about 6 years of age. They most commonly presented with respiratory infections or alopecia. And other presenting symptoms included endocrine abnormalities, severe herpetic infections, meningitis, nephritis, arthritis, secondary HLH, paniculitis, and autoimmune hepatitis. 71% were diagnosed with CVID, and the remaining patients were noted to be hypogam. More clinical manifestations noted in this paper, upper and lower respiratory tract infections were very common. Some skin infections with various herpetic bacterial species, Candida, PJP, CMV, EBV were also noted. The endocrine piece is also interesting, not something that I saw in my patient at all, but ACTH deficiency was not uncommon, and growth hormone, thyroid, and prolactin issues were also mentioned. In terms of autoimmunity, 80% had alopecia. Cytopenias were also noted, as were GI manifestations and arthritis. There was noticed to be some lymphocytic infiltration into organs such as the lung and the CNS, and lymphoproliferation featuring splenomegaly, but rarely lymphadenopathy. Malignancy was noted in 4 patients, including actually an acute leukemia and non-Hodgkin's lymphoma. In this same case series, 94% were hypogam. There were impaired vaccine responses, though the ability to mount a specific antibody response was at least partially preserved in over 50% of tested patients. I did not test vaccination response in my patient, of course, because he was on IVIG. T cells were not commonly low, so only 4 out of 37 patients had low T cells, but KA, of course, did have low T cells and reduced T cell proliferation. B cells were low in 60%, and NK cells in 30% 30%. So overall, this was described as an early onset PID with variable autoimmunity and variable penetrance. Another variation in phenotype was recently also described by the NIH group. Actually, I just saw the article last week in JCI. So showing haploinsufficiency in a pediatric patient with early onset CVID with a slightly different mechanism than the previous loss of function and gain of function mutations that have previously been reported. So KA went on to have progression of his liver disease and ultimately had a transplant. So he had a living donor transplant in September of 2017 done in Edmonton, Alberta. This was something we talked about at length, and I remember chatting with Sergio about it and a few other people because we always think, well, when you have a patient with an underlying immune defect, should we do, a sequential stem, or rather allogeneic stem cell transplant followed by solid organ? And I'll talk a little bit more about that in a few slides, but it was something we kind of wondered about. But he'd really done so well from an immune deficiency point of view that it was felt we should just proceed with the liver. Um, Donor and recipient were positive for CMV, and his post-transplant course was relatively smooth. He had C. diff, some abdominal pain, and neutropenia. He was prophylaxed with tacrolimus and Cellcept. And 5 months post-transplant had a transaminitis, which they determined ultimately was drug-induced, and it gradually improved. I just wanted to do a little review of liver transplant in CVID. I know we're talking about, an offshoot of CVID, and some might argue this mutation is a totally different entity. But I just wanted to review the literature on transplant in patients with antibody deficiencies. So Jorgensen et al. Looked at 6 patients that were transplanted between 93 and 2013, aged 19 to 62 years. 2 of them had Hep C, and they died with under 2 years post-transplant due to infection. They were immunosuppressed with steroids and cyclosporin or tacrolimus. 4 of them had NRH, which was probable or proven, with a median survival of only 5 years. All had infections post-transplant, and they were typically immunosuppressed with steroids, tacrolimus, and MMF. So they wonder if the differences in immune suppression and the indication for transplant may explain the variable outcomes. Ramlal et al. Looked at 2 patients with sclerosing cholangitis/cholangiopathy. It actually recurred post-transplant, and both died within 10 months after their transplants. Probably one of the largest series was published in 2018 by Azu, and there were 4 patients the one that had cryptogenic cirrhosis, who developed NRH and actually the graft, and then decompensated 3 years post-transplant, received a second transplant and had primary graft non-function and died within 24 hours. 3 had NRH, so infectious complications were a problem. In the first patient, you can see there was an AML developed. Another developed post-transplant infections, but actually was still alive at 5 years later. And then another developed recurrent NRH changes post-transplant with infections and deteriorated 2 years later. So not a great success rate with those patients. They then looked at prior case reports for a total of 18 patients of CVID and liver transplant. So 67% had CVID-related liver disease, 33 had viral hepatitis. And they then compared this to all-cause liver transplantation in patients in the US and the UK. So for all comers, there was an 89% 3-year survival post-liver transplant, which is excellent. But when you just looked at the CVID patients, it was 55%. So overall, the mortality I just wanted to comment here about the idea of allogeneic stem cell transplant and whether that would be something that's feasible. And unfortunately, these buttons are covering up my slide, so I can't see the percentage. But the mortality was very high in providing allogeneic stem cell transplants to CVID patients, and there's no evidence that it actually would prevent recurrent liver disease. So I last saw KA about a year ago, and I'm due to see him again very soon. But last year we did repeat labs. His CD3 count is now normal, but CD4s remain low. He has, of course, still low B cells, and NK cells are now normal. His platelets have remained low. His spleen is no longer enlarged, but he has an ongoing what seems to be ITP. And he also remains a bit neutropenic, and I suspect that might be the MMF. He's currently immunosuppressed with tacrolimus and MMF, but about 50% doses compared to what he was started on. So he's now 3 years post-liver transplant, no significant infections. Liver enzymes are almost normal. He's back at work and has good quality of life. And so really, so far, a good outcome to this case, though having reviewed some of the other data looking at liver transplant in CVID patients, I'm concerned about his future, but he's made it further than many of the patients reported certainly have. Any questions or comments? And I just wish I had all the answers, but I don't. Okay, well, if there aren't any questions or comments, I will hand it over. Oh, Harry Lee's long-term surveillance. Yeah, so I mean, he is getting surveillance from a transplant point of view from that team. I'm just going to continue to watch, and I think I may do. I wouldn't mind doing a repeat CT scan at some point. Continue to watch his numbers and just for any manifestations of CVID. I think just the routine kind of follow up that I would do for the average CVID patient. But certainly, if there's any other suggestions, I'm open to those. The survival with cirrhosis without transplant. I don't have the answer to that question. I'm not sure what his survival would have been if he hadn't received a transplant. I think his quality of life was so poor that I think it was not feasible for him to carry on. NRH, nodular regenerative hyperplasia. Sorry, I should have spelled that out. No, I don't. I'm not aware of any clear guidelines for this. From Harry asking about guidelines for lymphoma. Surveillance and CVID. I'm not aware of any. It would be certainly nice to have some. I mean, when I think about I also treat lymphoma. When I think about how I surveillance those patients after I've treated them, there's really no specific. It's mostly clinical. We don't often do surveillance CT scans post treatment, so I'm not sure there'd be a role to do it kind of as a pre-treatment thing either. It might just lead to further investigations that might lead us down a rabbit hole. With that, I will turn it over to Candace, who has a very interesting pediatric case to share with us this evening. Thank you, everyone.
Thanks, Jen. That was great talk. Really interesting, and I'm glad he's doing so well. So my name's Candace, as Dr. Grossman introduced me. I'm presenting an interesting case that we had recently here at the Alberta Children's Hospital. I'm going to be presenting my mentor, Dr. Nicola Wright. So any questions, feel free to address them to me or to Nikki. So this clinical case was a newborn late preterm. They were born at 36 and 1 weeks. They were male, and they were born outside of the Calgary Centre in one of our rural sites in Alberta, and they were found to have severe congenital leukemia. They had a bit of a complicated pregnancy history. The pregnancy history was complicated by a known diagnosis of maternal antibodies from a previous pregnancy. So mom was anti-D, anti-C, and anti-JAA. Because of that, they were being closely monitored, looking for fetal anemia. And the way they were monitoring that was by looking at the middle cerebral artery peak systolic velocity. And they found that that was worsening. When it was found to be decreasing, they actually did a fetal hemoglobin check. And they got a sample from one of the umbilical vessels and were found to have a fetal anemia of 86. So actually got an intrauterine transfusion around 33 and 1, which increased the hemoglobin to 158. The mom then went into preterm labor around 36 and 1 and delivered this little boy. There was no maternal fever or fetal tachycardia during the delivery, and no clinical evidence for infection in the perinatal period. He was admitted to the NICU because of the significant leukopenia that was seen on the cord gas and the CBC when he was born, and also to monitor because of his minor blood group incompatibility, looking for signs of hyperbilirubemia since he was DAP positive. A little bit more information about the family. They are a Hutterite family from northern Alberta. And so this is, for those who aren't aware, this is the map of Canada. Alberta is the Army Green province. And there are Hutterite families throughout the prairies, Alberta, Saskatchewan, and Manitoba. This family did have consanguinity, as mom and dad were second cousins. The family already had a 4-year-old daughter who was healthy and well. Mom and dad were also both healthy and well, with no major history of recurrent infections or autoinflammatory disease. Mom had one previous spontaneous abortion around 20 weeks gestational age, and no further assessment was done of that spontaneous abortion. On further history, the patient's maternal grandmother had 2 children, 1 male and 1 female, who both died in infancy. It was thought that they had died from CIS. Both of them died around 3 months of age. And I apologize, I missed that one name. On examination in the NICU, the child was very well appearing, non-dysmorphic. Really the only thing, this is all very healthy and normal, that they found on physical examination was that he was a bit pale, but that he was well perfused. His cardiac and respiratory examination were fine. His liver and spleen were normal on size. There's no major sign of hepatosplenomegaly, and no major rashes, dermatitis, or skin changes. On preliminary investigations, as mentioned, his neonatal hemoglobin was 86, which came up to 158 post-transfusion. After delivery, he was found to have a hyperbilirubinemia with an elevated total bilirubin of 117 in the first 24 hours of life. Post-delivery CBC found a hemoglobin which was normal and appropriate at 162. Platelets were normal at 155, but the white blood cells were found to be significantly low at 0.2, and a manual differential wasn't possible at our institution because of the low level of white blood cells. This child was transferred from the more rural hospital to the tertiary children's hospital in Calgary. While in hospital, was found to have a persistent leukemia, and because of that was started on GCSF with minimal improvement. He was found to have hyperbilirubinemia, requiring phototherapy, and the phototherapy led to improvement to his bilirubin levels. So at this point, I just wanted to pause to see if anyone had any thoughts on what the differential diagnosis for this child is and what further investigations they would like to do at this point. Any evidence of ABO incompatibility? Platelets were normal in number. As far as ABO incompatibility, they had a positive DAT, but the blood groups, I don't believe, were suggestive that there was ABO incompatibility, but there was an element of incompatibility with the minor subgroups. A Marrow is a great idea. Any thoughts on what the underlying diagnosis might be? Oh, sensory neuro deafness, great suggestion. Anything in particular, Amit, that you'd be thinking of with the sensory neuro deafness? Reticular dysgenesis with an AK2 deficiency. Barbara suggests SCID, and Nicola Wright mentions that there's known RBC allo-AB and hemolysis. And Anthony mentions that Moisen is a possibility as well. There's too many options at this point, and I agree. The differential at this point is quite broad, both looking at immunologic as well as non-immunologic diseases. So as mentioned by the chat group, you can look at this from a hematologic standpoint. This could be post-neonatal transfusion leading to bone marrow suppression, leading to a transient neutropenia. This could be neonatal alloimmune neutropenia or congenital neutropenia. There's also a lot of infections that can be associated with low white blood cell numbers and neutrophils in this period. So a lot of your torch infections, specifically parvo, toxoplasma, syphilis, HIV, and CMV. And then from an immune standpoint, you need to wonder about severe combined immune deficiency, and given the significantly low number of white blood cells, you wonder about reticular dysgenesis or AK2. Was there reticular cytopenia? So far, the only investigations that we had in this patient were the CBC, which showed 0.2 white blood cells. So we hadn't done any further investigations at this point. So we did do further investigations, and so we did some immunoglobulins, which found a normal level of IgG, most likely at this age entirely maternal. We found to have low IgM, IgA, as well as IgE. We also did a lymphocyte enumeration, which found pretty much no CD3s and CD4, CD8 T cells. There was some B cells and low numbers of NK cells. Newborn metabolic screen is available in Alberta, looking for TREC screens, and the initial newborn metabolic screen came back with insufficient sample requiring recollection. And the reason that it was considered an insufficient sample is because there was not high enough levels of DNA in the sample for the control to meet standards. So what ended up happening with this child was that we ended up doing a genetic screen, and the genetic screen came back with homozygous mutations in the AK2 gene suggestive of reticular dysgenesis. Specifically, it was a homozygous mutation, which is known, a deletion in the AK2 gene, which is known to be pathogenic. So reticular dysgenesis is as many of you guys know, is an autosomal recessive, rapidly progressive form of SCID, which is associated with agranulocytosis, sensory nerve hearing loss, and mutations in AK2 or Adenylate Kinase 2. It's quite a rare form, and specifically of note, it hasn't been previously seen in our Hutterite populations in Alberta. It's about less than 1% of the SCID cases. In a PIDTC cohort, there was only 2 out of 285, and one of the papers looking at newborn metabolic screens in the States found no cases of reticular dysgenesis in about 3 million babies screened. The first case of reticular dysgenesis that I found in publication was in 1959 by Deval et al. As mentioned, the clinical manifestations of reticular dysgenesis that make it different from severe other forms of SCID are the significant agranulocytosis that you can see early on, secondary to early arrest of the myeloid differential in bone marrow. And often these patients will not be responsive to GCSF. They also have significant lymphopenia, and absent thymus, and sensory nerve hearing loss is seen in about 88% of patients. This is just what the structure of the AK2 gene is. Adenylate kinase is a phosphotransferase involved in intracellular energy transport. Specifically, it's an enzyme that's involved in mitochondrial energy metabolism, and it regulates the homeostasis of the ATP plus ATM, leading to conversion to 2-ADP. Some studies have found that this is the only kinase, or adenylate kinase, that is functional in bone marrow, which explains why an AK2 mutation has such significant impact on the immune system and not as much of an impact on other ones. Harry, to answer you, the AK, because the patient had such significant lymphopenia, we ended up doing a primary immunodeficiency panel, but we specifically wanted to look at the AK2 mutation because we were concerned about SCID. So it was, I believe it was a panel rather than a whole exome. So one of the things that we really learned from this case is that newborn metabolic screens are fantastic, and the TREC screen does a really good job of looking for certain types of SCID. There are forms of SCID that you're not going to pick up from it, and one of the take-home points that we had is that although reticular dysgenesis will obviously have an abnormal TREC screen, in our case, because they have such significantly low levels of lymphocytes, the control was showing insufficient as well. And so that led to a bit of a delay in the diagnosis of this patient because the newborn metabolic screen results came back as insufficient. And so a second sample had to be collected. And then the second sample also showed insufficient amounts of DNA. And so it was at that point that we did further immune assessment. So bone marrow transplant and reticular dysgenesis is a fascinating topic. There was a really great summary paper put out by Honig et al. In 2017, looking at the 32 different bone marrow transplants that were done in reticular dysgenesis between 1982 and 2001. The very first bone marrow transplant was described in 1959 by Duvall et al. This bone marrow transplant was the first successful bone marrow transplant correction was in 1983 by Levinsky and Tideman. It was the donor was an HLA identical brother, and no conditioning was done. The patient had significant GVHD disease following the transplant. The GVHD disease did resolve, and the patient was alive for 3 years post. Looking at the summary paper by Honig et al. Looked at 32 different patients between 1982 and 2011 that had hematopoietic stem cell transplants. The male to female ratio was fairly equal, with 17 to 15, boys versus girls. There was a predominance of the patients with reticular dysgenesis to be premature, and 62% were small for gestational age. Most of the patients presented quite early on. Reticular dysgenesis has a tendency to present quite early because the significant lymphopenia leads to increased risk of infections even within the first couple of weeks of life. The mean age of transplant in these patients was around 3.5 months. The 32 patients that were published in this paper, 31 underwent 47 different transplants. Fortunately, one of the patients passed away before transplant was possible. About 13 of the 31 patients required a second stem cell transplant. The most common reasons for a repeat stem cell transplant in these patients was engraftment failure in 5 of the patients, and persistent or recurrent agranulocytosis in 8 of the patients. The secondary transplants were more common in patients that had a non-myeloablative conditioning regimen or were T-cell depleted transplants. The patients that were published, 17 were mismatched family donors, 6 or 19% were matched family donors, 8 were unrelated marrow or cord donors, and as I mentioned, 1 patient died before the transplant could have occurred. I apologize for how busy this slide is. This is an excellent graph from the paper, but obviously it's quite small. The summary is just to the left. So when you look at these patients, about 13 of the 31 had T-cell replete grafts, and 17 had T-cell depleted grafts. And so there was quite a significant difference in survival between the T-cell replete and depleted grafts. The T-cell repleted grafts had a survival of about 93%. Of those patients, 6 had identical family donors, and all of those had survived. 5 of those 6 patients were conditioned. 1 of those patients did not have conditioning. They did require a second bone marrow transplant. Outside of the 6 identical family donors, there was 8 unrelated donors. Their survival was also quite good at 88%. Of those, 6 were an unrelated cord with conditioning, and 2 were an unrelated bone marrow donor with conditioning. Of them, they had quite a good survival, except for 1 patient who died from VOD. So the T-cell repleted grafts, and specifically those with conditioning, seem to have quite good outcomes. Unfortunately, these patients require that you have a fairly good matched donor, which not all patients have. The other 17 patients with reticular dysgenesis had a T-cell depleted graft from an HLA haploidentical donor, and unfortunately the survival in these patients was only 47%. Of these patients, 5 had no conditioning, and all of those patients had graft failure. 4 of them had a repeat stem cell transplant, and only 1 of them survived. The remaining 12 patients had some form of conditioning. 6 of those had a permanent cure. 2 died from graft versus host disease or sepsis, and 3 required a second transplant. And unfortunately, all 3 of those with a second transplant passed away. The complications that are seen in reticular dysgenesis post bone marrow transplant are infection, with 59% of the patients having bacteremia and 17% having encephalitis. And agranulocytosis is a significant complication post bone marrow transplant in these patients. 8 of those required a repeat stem cell transplant due to persistent or recurrent agranulocytosis, and 3 of the patients died post-transplant because of ongoing issues with agranulocytosis. This graph here really summarizes what I was speaking about further when you look at T-cell depleted versus T-cell repleted bone marrow transplants and reticular dysgenesis. There is a significant survival difference. Showing patients with a T-cell transplants with T-cells showing better outcomes. As far as post-transplant mortality, 7 of the patients died in the first 6 months post-transplant. 6 of those were due to infection, and 1 of those was due to severe graft versus host disease. 3 of the patients with reticular dysgenesis died greater than 6 months post-transplant, and all of those were secondary to persistent or recurrent agranulocytosis. So the summary of recommendations coming out of this paper, based on these 31 patients who had stem cell transplant, is that to consider reticular dysgenesis when you have unexplained neutropenia in the neonatal period. Also, from our case, to consider reticular dysgenesis if you're getting insufficient samples or errors in your newborn metabolic screen. Confirmation is best done with phenotyping, hearing test, bone marrow morphology, and genetic sequencing for the AK2 gene. Myeloid engraftment, I think the real take-home point from this paper was that myeloid engraftment really plays a critical role in the permanent cure for patients with reticular dysgenesis. Myeloid engraftment is supported either by conditioning with myeloablative agents or by transplant with a T-cell replete transplant. And if you're primary or secondary, you've seen primary or secondary failure of the graft, consider a second transplant early on. And I'm just seeing there's a couple questions here on the side. Was there a difference of survival or engraftment with respect to conditioning regime? Oh, yeah. Thanks, Carl. I didn't go too much into that. The paper goes a little bit more into detail. For the most part, which conditioning routine didn't show as much as a difference, whereas the bigger difference really just seemed to be there were T cells in the donor, or if there was conditioning and specifically myeloablative conditioning. So back to our case. So unfortunately, after we diagnosed this patient with reticular dysgenesis, we went on for a donor search, and there was unfortunately no matched family donor. We also didn't feel we had the ability to wait for a matched unrelated donor, given the data showing that, given the significant risk of infection, that an urgent transplant is quite critical in these cases. So the best option that we had for this patient was a maternal 6 out of 10 haplo. Unfortunately, we couldn't do a haplo with the father's bone marrow because there was donor-specific HLA antibodies to dad. The donor was CMV positive, HSV positive, and varicella positive. And interestingly, the patient also was CMV positive, HSV positive, and varicella positive. The CMV positivity was quite interesting. The initial blood work that was done on this patient after birth was that their CMV was negative. Mom breastfed for the first 5 days of life until they were transferred to a tertiary hospital, and immunology saw and recommended discontinuing breastfeeding because of the risk of CMV disease. Interestingly, at 5 days of life, breastfeeding was held, and the patient didn't become CMV positive until almost 2 months of life, so about 4 to 6 weeks after the breastfeeding was discontinued. So it is a bit of a mystery where this CMV positivity in the recipient came from, whether this was a delayed in positivity from breastfeeding or if the patient might have been exposed to CMV. They were in hospital that entire time, and so it would have been a hospital-acquired infection. They did not have any CMV disease. They just had CMV positivity. As far as the bone marrow transplant went, we used TCR alpha beta selected bone marrow, which was B cell depleted. The day 0 was just around 2 months of age. The CD34 dose was 12 times 10 to the 6, and the TCR alpha beta cell dose was 41 times 10 to the 4. The conditioning regimen that we used was fludarabine with triosulfan, ATG, and thiotepa, and a low dose of Ritux. The GVHD prophylaxis that we used was MMF and cyclosporin, which eventually needed to be switched to tacrolimus due to central line issues. So the post-transplant course for this little guy actually went quite well. He engrafted by day 16 with no evidence of VOD or graft versus host disease. He's currently 11 months post-transplant now and has normal IgG, IgM, some low IgAs, and is off of IVIG. The top chart I have there is just taking a look at his lymphocyte enumeration at 3 weeks, 15 weeks, and 6 months. You can see initially he had quite low cell numbers across the board, but around the 15-week mark started creating some T cells, and then around, but had quite low B cells. And then around 6 months was showing good numbers across the board. Obviously, that's just looking at absolute peripheral numbers. It's not looking at chimerisms. So the lower chart there looks at the chimerisms. It's not surprising that the B cell numbers were insufficient, given that he had a low dose of Ritux, but he obviously recovered his B cells quite quickly. Here at 9 months out was found to have good chimerisms in his T cells, NK cells, and myeloid. Sorry, at 6 months had good numbers in his chimerisms in his T cells, B cells, NK cells, and myeloid cells. Unfortunately, at 9 months, we're seeing a little bit of a drop, both in his B cells and unfortunately in his myeloid cells as well. And then there's just a comment saying another point that I learned from our AK2 patient is that GCSF is not helpful and can even cause myelodysplastic syndrome. Sorry if this has already been brought back up. And it hasn't been brought up yet, but it's definitely one of the things I'm going to talk about shortly. So our patient's clinical course was complicated by some infections, some challenges with CMV and neutropenia, as well as sensorineural hearing loss. So as far as infections go, we've gotten out quite lucky because the staph, he's only had one major infection, which is a Staph aureus infection, an enterococcus infection of the central line. Responded well to therapy, and the Broviac line was removed as it was broken, and he's had no further infections since. The second challenge that this patient had was the CMV, which I alluded to a little bit earlier on. So the initial diagnosis, mom was found to be CMV positive, and breastfeeding was stopped on day 5 of life. But the patient actually became positive just 4 days before the scheduled transplant, just before 2 months of age. So the patient was initially followed and not started on any CMV treatment, but ganciclovir was started on day 10 post stem cell transplant because of increasing CMV viral load. He was switched from valganciclovir to valganciclovir because he lost his central line. And throughout this, there was no sign of CMV disease. So he had an ophthalmologic examination, which showed no retinitis, no CMV pneumonitis, and no signs of CMV hepatitis. Unfortunately, his CMV viral load continued to increase, and so a CMV sensitivity test was done, which was suggestive of ganciclovir resistance, and so he was switched to foscarnet. Fortunately, he responded well to the foscarnet and was continued on that until his CMV levels returned to 0. The real challenge that Hay alluded to was that this patient is having evolving neutropenia. So initially his ANC was greater than 0.5 by day 5 post-transplant when he engrafted. And he had a stable ANC until around 4 to 6 weeks post-transplant. And then we found that his ANC started dropping down. Initially, we weren't sure if this was secondary to infection because of his ongoing CMV disease, bone marrow suppression because of the medications he was on, specifically the ganciclovir, if this was autoimmune neutropenia because of the pregnancy history and autoantibodies, or as suggested, if this was early myelodysplastic syndrome or an early loss of the myeloid graft, which can be seen in these patients with reticular dysgenesis. It's a great question. In the chat is, was there a drop in the myeloid chimerism? As you can see, I'll just go back here. So this was around 6 months of age, and so at 6 months, our myeloid component was 100% in the chimerisms. T cells were also 100%. So at this point, the chimerisms were looking good, but the ANC was starting to drop down. The next time we repeated the chimerisms was at 9 months, and at that point we did see a drop in the myeloid chimerisms. So the next question I ask you is there any investigations that you would do with respect to neutropenia? For time's sake, I'll just move ahead. So we did an infectious workup looking for that to be the cause of neutropenia, and we didn't find anything. We did do an autoimmune neutropenia workup and found that there was a low positivity to the anti-neutrophil antibody. A bone marrow was done, which showed good cellularity. Unfortunately, the bone marrow found a small clone of CD34, CD117, CD13, CD33 positive myeloblasts, which featured atypical maturation patterns. So a repeat bone marrow was done with cytogenetics, and you can see the results here. So unfortunately, it looks like in the bone marrow, there was several abnormal samples or cells that were examined. The majority of the abnormal cells were a male karyotype, which were found to have unique reciprocal translocations. The rest of the samples were found to be normal male karyotype and normal female karyotype. And just as a reminder, this patient's obviously male, and the bone marrow donor was female since it was his mother. Initially, he had been given some GCSF early in the transplant process because of his low ANC. But once these results were back, we stopped. We did not give any further GCSF due to concerns that were alluded to in the chat of promoting further your myelodysplastic syndrome. Sergio, to answer your question, my understanding is that the sensorineural hearing loss isn't usually corrected post-transplant if it's associated with the AK2. Harry's question is fetal hemolytic anemia a known phenomenon in reticular dysgenesis, and has this been reported in previous patients? Is a great question. My understanding from looking at the summary paper, Harry, is that hasn't previously been seen, but obviously fetal anemia is difficult to look at. When you are looking at the majority of the patients in the paper I saw, they actually had relatively normal or just slightly low hemoglobin levels. And so our feeling in this patient was that it was most likely secondary to the maternal antibodies. So the question that we wanted to just pass along to all of you here was whether or not, what to do next. So the summary paper looking at reticular dysgenesis argues that it's important very early on to look at a repeat bone marrow transplant if you're noticing that you're starting to have challenges with your granulocyte counts. And so given that we've seen some drops in the myeloid chimerisms and that we're having challenges with neutropenia, should we look at repeating a bone marrow transplant urgently? Should we continue to watch and see what the numbers do?
It's Nikki Wright. Candace, that's a great presentation, and we are all very interested to hear people's opinions and what to do with this kid. I think with the cytogenetics, the cytogenetic abnormalities are all in the recipient cells. So one of the questions is whether or not the donor cells are hopefully keeping that under control or not. But curious to hear other people's opinions as to what to do going forward.
So in the chat room, I think Carl said that obviously if the chimerisms worsen, your decision is made for you. I think that's very true. I guess the question is does anyone have a feeling on what their cutoff would be for when too low of a myeloid chimerism is too low?
There's also the question from Ravi about do patients with RD have an abnormal dysplastic clone to begin with, which is also a good question because there are some patients reported in the literature who have developed MDS post-transplant. So certainly a concern. So I suspect with their abnormal granulopoiesis, they are at risk of developing that. But with so few cases, it's hard to know. So another good question with, can there be a contribution of the hemizygous AK2 state? So that's a great question because mom was the donor and she was confirmed to be heterozygous for the mutation. That would be an interesting question to answer, whether or not having a carrier donor is not helping in this case. And then Luciano asked, does he have a matched unrelated donor? So pre-transplant, we didn't do a full search just because it was going to take a long time to actually get an unrelated donor. Some of the older data for reticular dysgenesis shows a very high mortality rate if you don't transplant them right away, which is one of the reasons why we used the haplo transplant. I think going forward, if you need to transplant him again, that is definitely something that we may want to look at using an unrelated donor as opposed to a parent. Okay, Amit, no, I do not think abnormal clones in BMT to begin with. And Carl, the question in hindsight is whether mom was a bad donor. That is a good question. Ravi, 80% myeloid chimerism is still good. I would worry if the platelet starts to fall or the bone marrow shows dysplasia. Barbara AK. And then John, would the rate of loss of chimerism help guide decision repeat transplant? And I think that's probably a good comment. Certainly this is a kid that we will monitor very closely. It's up for debate a little bit how frequently we will do bone marrows on him, certainly open to people's suggestions. And Ravi also mentioned, Ravi Shah is the transplanter managing this patient. We did a next generation sequencing panel that we do in our Center for MDS, and it was negative as well. So I'll have one last ask for comments or suggestions. Would anybody just go ahead and transplant this patient now? Okay, so Carl suggested only with the mud. I think that's a good idea to look at an alternative donor in this case for sure. And the Hutterite population was Caucasian, so we should be able to find a good donor directly for them. Harry suggested would watch a little bit more. He is significantly neutropenic. Thankfully, though, he's done extremely well without any problems with infections as well off GCSF. Carl, again, mom having autoimmunity might be a hint that there's an issue. And Terry with, sorry? with
Yeah,
consider watching.
Just for the last 2 months, to give everyone an idea, his neutrophils have been between 0.1 and 0.4 for the last 2 months. His platelets are still hanging on, though.
All right, should we move on to review the paper?
Yeah, just a big thanks to obviously the family, the bone marrow transplant team, including Dr. Shaw and the Nikki and Nikki. Thanks so much, Nikki.
Excellent presentation, Candace. Thank you. And Jen, yours was excellent and very interesting too. So traditionally at the end of the webinars, we review a recent Journal of Clinical Immunology paper. And I chose this one that came out in July, systematic review and meta-regression analysis on the impact of increasing IgG trough level on infection rates in primary immune deficiency patients on intravenous IgG therapy by Lee et al. And this group is out of Malaysia. So the purpose of this study was that we tend to use the IgG trough level as a surrogate of IgG efficiency when we're giving prophylactic immunoglobulin therapy. The optimal trough level to shoot for, however, is not clear. There's various recommendations, anywhere from keeping it over 500 milligrams per deciliter to over 1,000, or in our Canadian values, 5 to 10. Methods of the paper. So they did a systematic review in accordance with PRISMA guidelines, looking at papers from 2000 to 2019, and they assessed it using a standardized Minors scale. They then used a random effects model, assuming significant heterogeneity of the data, with outcome measures including infections, serious bacterial infections, missed school or work days, hospitalization, and antibiotic use or treatment. They then performed a fancy statistical breakpoint analysis to investigate the influence of increasing IgG trough levels on the incidence of rate of infections. So this is just their flow diagram of the papers that they looked at. In the end, they used 28 papers in the meta-analysis with data from 1,218 patients. So I've presented figure 4 first. This is a breakpoint analysis that they did because this was their primary outcome, really. So this was a segmented linear regression looking at IgG trough levels versus the rate of infection. So you can see that dotted line through the middle is what you call the breakpoint. So it's essentially the sweet spot of where you want to get your IgG trough levels. So below that level, what you're seeing is increased infections, whereas if you go above that 960 milligrams per deciliter trough level, then you're not really getting that much benefit. The graphs on the right beside that are looking at increasing IgG trough levels on the incidence of the secondary outcomes. So the top one is looking at infection. So as your IgG trough increases, there is a decrease in infection. However, it was not statistically significant. The next one is looking at missed school or work days. And again, there was a decrease, but not statistically significant. And the final graph is looking at hospitalizations. And with increasing trough levels, there was a statistically significant decrease in hospitalization rates in the patients. So the conclusions in this paper, a few other things that they found were that your IgG trough level increases significantly by 73 milligrams per deciliter with every increase of 100 milligrams per kilo per dose, so it's relatively predictable. They found their overall infection rates reduced significantly by 13% with every increment of 100 milligrams per deciliter of your trough up to that breakpoint of 960 milligrams per deciliter. They did some analysis as well, looking at adverse events for infusion, and their pooled event rate for adverse events was 0.22 per infusion. They did not find that increased with increasing IgG trough, Cmax, or infusion rates. And they suggested at the end to infuse at 0.01 mils per kilo per minute for 30 minutes, increasing by every 15 to 30 minutes to a maximum of 0.08 mils per kilo per minute. Some of the limitations of this study were that the baseline endogenous IgG level may actually affect your response. So they had different types of PIDs in all of these meta-analyses, and they were unable to pull out the different types of PIDs because they did not have the source data. So if you think about, for example, a patient with XLA who has no IgG at baseline, compared to a patient with CVID who may have a higher baseline, if you get an XLA patient up to 960, that's a pretty significant change, but it might not be that significant in a CVID patient. So there's some suggestions that perhaps we should be looking more at an incremental IgG change from their baseline as opposed to what your actual trough is. So that's something that they weren't able to look at. And so I think at the end, this was some good data that helps guide our where do you get the trough level to be in patients who are on IVIG replacement. This study also did not look at subcutaneous immunoglobulin. So a question from Harry. Did they look at other outcomes such as control of autoimmune symptoms? And they did not. They were only looking at those secondary outcomes that I mentioned. Any other questions on that study or any other questions overall? And certainly we're happy if you guys want to contact us or email if you have any suggestions on our reticular dysgenesis patient. And thank you so much for the very interesting discussion and all the comments with regards to both cases. And a question from John, how might you extrapolate these data to sub-Q IG use? Is it impossible? I think you might be able to extrapolate and think that you would want to keep your steady state IgG level at around 960, but really to show that for sure, we're going to have to do the studies to show what is the best sort of steady state IgG level in those patients, I think. That's a great question. And if there aren't any other final questions, thank you so much to Jen and to Candace and also to CIS and Morgan for having us have the opportunity to present. And we look forward to the next webinar.